Welcome to Artificial Intelligence in Medicine, Foundations, Use Cases, and the Future, Understanding AI Fundamentals and Healthcare Applications. I'm Dr. Mark Mabus. I'm the Chief Medical Informatics Officer and SVP of EHR at Parkview Health in Fort Wayne, Indiana. I'm also a family physician, so I'm right there with you when it comes to the daily grind of seeing patients, documenting visits, answering the endless stream of messages, and keeping up with all the quality requirements that somehow never seem to end. And that's why this talk matters. We're going to talk today about artificial intelligence in healthcare. And let me set the stage right up front. This is not about replacing doctors with robots. That makes for great Hollywood plot lines, but it's not reality. AI is not here to take your stethoscope. It's here to make your life more sustainable. It's about fewer clicks, less pajama time, fewer nights where you're explaining a lab result for the 37th time in the exact same way. It's about creating space for the real reason we went into medicine, relationships with patients. This is a little bit more about me on that slide. But here's what I want to cover in the next hour. We're going to talk about a plain English introduction to what AI actually is. There's different flavors of AI, the rule-based, the machine learning, the neural networks, generative and agentic, and then how AI has already been a part of our workflows for years. We'll talk about how it's helping in EHRs like Epic, Cerner, and MEDITECH. We'll talk about what's coming in the near future, including things like Epic's Comet model and the new assistants you may have read about. We'll do a deep dive into ambient AI and highlight how it reduces burnout and increases provider satisfaction. And then governance and legislation, because we need to use these tools safely and responsibly. And along the way, I'll share some of my stories with Parkview and Epic Systems and more, including our rollout of ambient technology last year. So let's dive in. We'll start with the fundamental concepts of artificial intelligence. When you hear the phrase artificial intelligence, what comes to mind? For some people, it's HAL from 2001: A Space Odyssey. And for others, it's ChatGPT spitting out essays. For some of our patients, it might be robots walking around with stethoscopes, like I mentioned there. But let's strip away the hype. At its core, AI is just this: computer systems performing tasks that normally require human intelligence. In healthcare, that means a few practical things: recognizing speech, dictation and ambient scribing, interpreting images, radiology and pathology stuff, predicting outcomes, who's at risk for sepsis, or who's likely to be readmitted, generating text too, a drafted note, a patient message, a discharge summary. Now compare that to traditional software. Traditional programs follow rules. If systolic blood pressure is greater than 140, then pop up an alert. That's rigid, predictable, and often annoying. AI, on the other hand, learns patterns from data. Instead of saying if BP is above 140, it looks at thousands or even millions of patients with hypertension and figures out who did poorly and who did well, and what combinations of meds and labs and what comorbidities mattered in that whole discussion. That's flexible, but it's also a little less transparent. You don't always know the why behind the model and how it made its prediction. And that's where trust and oversight come into play. But let me bust a few myths right away. Myth number one: AI is going to replace doctors. No, it won't. The human relationship is at the center of medicine. What's more likely is this: that providers using AI will outpace providers who don't. Myth number two is that AI is brand new. Well, nope. We've had rule-based AI in EHRs for decades. Think drug-drug interaction alerts. Think immunization reminders. Think early predictive scores like sepsis models. What's new is the scale and the power. Well, myth number 3, it's only for techies. Well, that's wrong again. If you've ever used Siri, Alexa, Google Maps, rerouting you around traffic, you've used AI. If you've ever dictated into Dragon or Fluency, you've used AI. So here's my mental model for clinicians. Think of AI like a capable intern. It can draft, it can summarize, it can predict, but you're still the attending. You supervise, you correct, and you sign. And then also trust but verify. Ask what data trained this? How is it monitored? And always be ready to override. That's AI in a nutshell. It's not magic, it's math, but math at a scale that's finally useful in medicine. Let's start by reviewing the simplest form of AI, those rule-based systems. This is the one you already know, even if you didn't call it AI. Rule-based AI is basically if-then logic. If condition X is met, then action Y happens. It's like a flow chart coded into your EHR. Examples are everywhere. In Epic, you get a best practice advisory that pops up if a diabetic patient hasn't had an A1C in 6 months. In Cerner, you get that drug-drug interaction alert when someone prescribes lisinopril with spironolactone. Watch that potassium. In MEDITECH, you get a reminder that your patient is overdue for a colonoscopy. That's all rule-based AI. But what's good about it? Well, it's transparent. You know exactly why the alert fired because the logic is visible and it's predictable. And some of those EHRs show you that logic right there. But what's bad about it is it's brittle. It doesn't handle nuance. And it's responsible for a huge chunk of what we call alert fatigue. Raise your hand if you've ever clicked right past an allergy alert just to get your order signed. Me too. Rule-based AI is like that eager intern who pages you at 3 a.m. to say, the potassium is 3.5. Correct, but not helpful. But that was the foundation. It was our first attempt to get the computer to help us think about patient safety and preventative care. Next up, another type is machine learning. Machine learning is when the computer looks at a bunch of data, learns patterns, and instead of following those rigid rules, we kind of feed it examples, and it figures out the math behind the scenes. So in healthcare, the classic examples are sepsis early warning systems, vitals, labs, demographics, put them all together and try to predict which patients are at risk. Readmission risk scores, like I mentioned, taking hundreds of variables and saying this patient has a 40% chance of bouncing back within 30 days. And then also length of stay predictions too, helping hospitals plan beds and discharges. This is more sophisticated than that rule-based logic, but it comes with caveats. Machine learning models are only as good as the data that they're trained on. If a sepsis model was trained in Boston and you tried to use it in Indiana, it may flop. Different patient populations, different workflows, different baseline risks. Epic's sepsis model actually became a cautionary tale. It worked well at some sites, but at others it underperformed badly until it was tuned into local data. It actually worked tremendously well for us at Parkview, achieving some of the best sepsis bundle scores in the state by a large spread. U of M, not so much. But that's the lesson. Machine learning isn't plug and play. You can't just drop it in and expect it to work everywhere. You have to validate it locally. So the metaphor here is machine learning is like the resident who's really good at pattern recognition because they've seen hundreds of cases. But when they rotate to a new hospital, they need time to adjust to the new patient population. They're smart, but they're not omniscient. All right, let's turn up the sophistication another notch. Neural networks, also known as deep learning. If machine learning is about finding patterns in structured data, neural networks excel at unstructured data like speech, images, free text. This is where we've seen huge leaps in healthcare in the last decade. So some examples include, like in radiology, an AI that reads chest x-rays, spotting pneumonia or lung nodules. Pathology that looks at biopsy slides and flags suspicious cells. And then what more providers use is speech recognition, like Dragon dictation and its smarter cousin, nuanced DAX. These are powered by neural networks that learn to map sound waves to words. The power of neural networks is that they can handle incredibly complex tasks with accuracy that sometimes rivals humans. The downside is explainability. A neural network can tell you, looks like pneumonia, but it can't easily tell you why. The decision making is buried in layers of math. That's why some people call them black boxes. So the metaphor here is that a neural network is like your colleague who's brilliant at dermatology. They just look at a rash and say, that's pityriasis rosea. You ask how they know, and they said, I just know. They're usually right, but the explanation isn't always clear. That's neural networks, powerful, impressive, but sometimes hard to interrogate. And now we come to the form of AI that has captured all the headlines, generative AI. Unlike traditional AI, which predicts or classifies, generative AI actually creates. It can draft new text, produce new images, even generate code that computer programmers use. You've probably heard of ChatGPT or Gemini. That's generative AI. In healthcare, we're now seeing very practical applications, drafting responses to patient messages in Epic's InBasket. Instead of starting from scratch, you get a suggested reply you can review, edit, and then send. Writing portions of your discharge instructions. Instead of typing, take lisinopril every morning to protect your kidney and heart, the AI drafted it for you already. Also, maybe summarizing the chart for a covering provider by condensing 20 notes, all the labs, and imaging into a one-paragraph handoff. Generative AI can save minutes on every task. Multiply that by dozens of encounters, and suddenly you've freed up real time. But here's the catch: hallucinations. Generative AI can be confidently wrong. It might fabricate a fact, invent a lab value, or cite a guideline that doesn't exist. That's why human in the loop obviously still matters. These are drafts, not gospel. You are still the author. So here's this metaphor. Generative AI is like a scribe with a literature degree. It can draft beautifully in your style, but you still need to proofread it. If you just hit sign, you may be in trouble. If you've ever had Dragon mishear you, just imagine what could happen if generative AI decides your patient's blood pressure medicine is actually a blood thinner. Proofreading is non-negotiable with generative AI. Used wisely, though, generative AI can shave hours off the work week and get you home sooner. All right, let's talk about the newest frontier called agentic AI. If generative AI writes a draft, then agentic AI goes one step further. It actually takes actions to achieve a goal. Think of it as an AI with a to-do list. You tell it the goal, it plans and executes the steps with audit trails and boundaries. Here's an example in healthcare. The AI sees a patient's chart, recognizes they need a prior authorization, pulls in relevant labs, imaging, attaches the guideline references. It fills out the prior auth form and then drops it in your queue for your review and signature. You didn't touch the paperwork, you just reviewed and approved. Another example is in-basket triage, where instead of manually sorting every message, an agentic AI could route the refill request with no changes to an auto approval under standing orders. It could flag that new chest pain message as urgent, and then leave all the gray zone messages for you to decide what to do with. How about seeing a patient for a medication refill visit? The refills needed monitoring, labs, and diagnoses for that visit, could all be queued up before you walk into the room. Now, we're still early in agentic workflows here. These systems need a little bit more heavy governance, transparency, and monitoring, but that's where things are heading. So metaphor for this one, if generative AI is your intern drafting the note, then agentic AI is like your resident who not only writes the note, but orders the labs, calls the patients with their results, and tees up your discharge summaries. You're still responsible, but the grunt work has all been done for you. And when Epic, Oracle, and MEDITECH all say AI first, this is what they're actually talking about. systems that don't just suggest, but they act safely under supervision. If agentic can take prior auths off my plate, I might actually start believing this technology is on our side. All right. So that's a little background about AI, some different classifications, and kind of the history of where it is and where it's been and where it's going. But let's take a look at how those workflows actually worked in the past. So in the past, AIs, like I said, have been part of our workflows for years, but we just didn't call it AI before. Remember those earliest forms, the rule-based decision support. Again, if you've ever been interrupted by a pop-up reminding you to order a tetanus booster, congratulations, you've used AI. The drug-drug interaction alerts, like that example I used with lisinopril and spironolactone, those are great, sometimes helpful, sometimes maddening. Predictive scores like the sepsis models, readmission risk scores, lengths of stay predictions. These were early machine learning tools. They tried to learn from data and flag risk before it happened. Sometimes they worked and sometimes they missed. Well, and then dictation. Remember Dragon before it got smarter? That was powered by neural networks, turning speech into text. Yes, sometimes sinusitis turned into sinus sight is, but it was still AI under the hood. The truth is, AI in its earliest forms was clunky. It often created as much frustration as it solved, but it laid the groundwork. So when people say AI in medicine is brand new, the reality is we've been living with it for decades. It just wasn't powerful enough to change lives until now. So fast forward to today, AI has grown up a little bit. And for clinicians, the biggest pain points that it's starting to help are the ones that we feel every day: the in-basket, the note, and the chronic disease care. So looking at the in-basket, the average family doctor gets dozens of patient messages a day. There's questions about blood pressure, lab results, refills. Can I get a note for work? Generative AI can draft safe, personalized replies in your voice. You still get to review and sign, but instead of starting from a blank screen, you're editing a draft. That's faster, and patients get quicker responses. In notes, this is where ambient AI comes in, which we'll get into a little bit more in detail soon. But instead of typing furiously while trying to maintain that eye contact with the patient, ambient systems listen and draft a note for you. You review, tweak, and sign. At Parkview, we piloted Nuance DEX ambient, and clinicians said things like, "I felt like I was actually looking in my patient's eyes again." That's huge. Also, chronic disease care. Epic has a functionality called Best Care Choices that lets you see in real time what patients works best for patients like this one, not just from guidelines, but from millions of real-world encounters in their Cosmos database. That means when you're treating diabetes or hypertension, you can see which regimens were most effective for people with the same comorbidities and demographics. So instead of all of us doing N=1 experiments with our patients, we can learn from millions of cases all at once. This is where AI is today, not flashy robots, but practical helpers tackling the things that drain our time and energy. Let's zoom in on Epic since many of us use it. Epic has been aggressive about integrating AI into everyday workflows. I mentioned Best Care Choices. This pulls Cosmos data to show what worked best for patients like this. It's live already in limited release for conditions like diabetes, hyperlipidemia, and hypertension. So yes, Clippy is back, but this time instead of saying, "It looks like you're writing a letter," it says, "It looks like you're trying to manage diabetes. Here's what worked for 1 million patients like this." That's a little more useful. The Cosmos median length of stay. This helps inpatient teams set expectations for discharge. Family medicine physicians doing inpatient work can use this to anticipate barriers and improve planning. And in many cases, it's already proven superior outcomes to the standard geometric mean length of stay, or GMLOS. In-basket drafting is on there. Early pilots at places like the Mayo Clinic showed that generative AI drafting cut message response time significantly. Nurses and physicians said this made my inbox manageable again. And then there's the big news, Epic's new AI assistants. They've named Art the clinician assistant, which summarizes charts, flags risks, and drafts plans. Emmy, the patient assistant in MyChart, which answers questions, translates results into plain language. And then Penny, the revenue cycle assistant. Yeah, that's appropriately named, I guess. Dealing with coding and denial management. Epic is also working on foundational models built on Cosmos data. The big one is called Comet, Cosmos Medical Event Transformer. It predicts disease trajectories and outcomes based on hundreds of millions of de-identified records. It's like one master risk score for everything. That's coming soon. It's a glimpse into the very near future at Epic. Let's look at Oracle Health, formerly Cerner. After Oracle acquired Cerner, they talked a lot about being an AI-first company. Their vision is a little different in branding, but the themes are basically the same. Voice-first documentation. They want to make ambient scribing a core part of the Cerner workflow. Predictive analytics for population health. Think large-scale models looking at risk across thousands of patients in registries. And conversational assistants, tools that help both patients and clinicians interact with the system using natural language. They've been showing prototypes of a Cerner native ambient scribe, similar to what Epic is doing with its own native ambient solution, as well as with third parties. The idea is to reduce dependence on third-party vendors, though. If they build it into their EHR, reduce dependence on third-party vendors. Oracle is also talking about embedding AI into their database and cloud infrastructure, not just into the EHR interface. They want AI helping at every layer, from back-end efficiency to clinician-facing workflows. Now, do they have the same scale as like Epic's Cosmos? Well, not yet, but they're moving in the same direction. Ambient documentation, predictive insights, and assistance to make the EHR feel more like a partner and less like a punishment. Oracle calls it AI first, but some of us are still waiting for usability first. But to their credit, they are investing heavily in AI because they know their clinicians are drowning. Now let's turn to MEDITECH. MEDITECH serves a lot of community hospitals and smaller health systems. Historically, those organizations just haven't had the budgets for cutting-edge pilots or extra scribes. So MEDITECH has leaned into baking AI directly into Expanse, their EHR platform. Their big play is integrated ambient documentation. So instead of needing that third-party contract like I just mentioned, ambient note drafting is part of Expanse. That's a big deal for smaller systems. It means even a rural family practice doc can have access to the same kind of relief that large academic centers are piloting. They're also experimenting with AI-driven intake forms. Think of a patient filling out a symptom questionnaire online. The AI summarizes the free text into a structured chief complaint and history before you even walk into the room. And they've signaled interest in patient-facing assistance as well, tools that help patients navigate portals and understand instructions. The takeaway here is this isn't just for the Mayo Clinics and Cleveland Clinics and Johns Hopkins of the world. AI is being integrated into community-level EHRs, where most family docs practice. That's important for equity of access. For years, smaller health systems got the hand-me-downs after the big academic centers tried things out first. MEDITECH is trying to skip that and bring ambient and AI directly into community clinics. That levels the playing field. All right, so let me ground this in a real-world case study from UPMC. UPMC studied the effect of AI-driven charting and ambient documentation tools on physician time. The result? Well, on average, physicians saved about 2 hours of pajama time during day. 2 hours. Think about what 2 hours a day means. That's time to have dinner with your family. It's time to read a book or exercise or actually sleep. That's 10 hours a week, basically a part-time job you're getting back. This wasn't theoretical, this was measured in time. Clinicians reported that ambient AI meant their notes were essentially done when the patient left the room. The burden of reconstructing the visit hours later disappeared. And patients noticed too. They said their doctors were looking at them looking at them in the eye more. They felt heard, and that's a win-win. So the UPMC example shows what happens when AI is implemented well. It doesn't just save clicks, it gives clinicians their lives back. Let's look at another real-world case, this time from Mayo Clinic. Mayo piloted Epic's generative AI for in-basket message drafting. Now, if you've ever opened your inbox and seen 50 unread messages, you know what a soul crusher that can be. So here's how their pilot worked. Patient sends a message. My blood pressure at home has been 140/90. What should I do? AI drafts a response. Thank you for checking your blood pressure. That number is slightly above goal. Please continue current medicine and schedule a follow-up visit in the next few weeks. Let us know sooner if you develop new symptoms. The clinician reviews that draft, edits if necessary. Yeah, I might have said that a little bit differently myself. But then, edits and clicks send. That may not sound revolutionary, but think about the time saved. Instead of starting from a blank screen 50 times a day, you're just editing. The results at Mayo did show faster response times, so patients got their answers quicker. Happier staff, nurses and physicians reported less stress. No compromise on quality. Clinicians remained in the loop. And here's the key. Patients never got a raw AI response. Everything was reviewed by a human. That's critical for safety and trust. So when we talk about AI helping in-basket management, this isn't theoretical, it's happening. It's reducing workload, and it's doing it safely when humans remain in the loop. If AI can keep me from writing, your cholesterol is high, please eat more spinach for the 100th time, I'm all in. So let's peek into the near future, because AI is moving fast, and the tools we'll see in the next few years will go well beyond the inbox and the ambient tools. So here's what's coming. I mentioned those agentic assistants. Soon these assistants will handle tasks like prepping your chart before clinic, gathering labs and imaging for your note, drafting prior authorization packets with guideline references already attached, routing low-risk refills for auto-approval understanding protocols. That's hours of admin work disappearing. There's also smarter chronic disease management. So instead of flipping through years and years of labs and meds, AI will present the patient's A1C trend is rising. Among patients like this, GLP-1s had the best outcomes. We'll summarize the literature and for example, an Epic Cosmos data for you in real time. There's also population health at the point of care. Instead of saying 200 of your patients are overdue for colonoscopies, good luck getting them into GI, AI will say, here are the 25 patients overdue and at highest predicted risk. Start with them. So smarter prioritization. And then I mentioned Cosmos AI Lab and Comet. Epic is building foundation models on Cosmos data like Comet. So imagine sitting with a patient and being able to say, here's what usually happens for patients like you, and here's what interventions change the curve. Patients like you have a 40% risk of a heart attack within the next 5 years. Let's do something about it and change your life to hopefully prevent that heart attack from happening. So when we look to tomorrow, it's not about robots replacing us. It's about digital assistants finally doing the paperwork so we can do the people work. All right, let's shift gears now and focus on what I think is the most exciting, most tangible AI tool for clinicians right now, which is Ambient. Here's the elevator pitch. Ambient AI is like having a scribe in the room with you, but one that never calls in sick, never goes on vacation, and doesn't need a badge to get into the hospital. Works like this. During the visit, the system listens securely to your conversation with the patient. It processes that conversation in real time, and by the time you finish the encounter, a draft note is already ready, structured in your voice, covering the HPI, exam, and assessment and plan, and even patient instructions. What it doesn't do is it doesn't order meds on its own. It doesn't send messages directly to patient. It doesn't replace your judgment. You're still the author. You still review and sign. The difference is Instead of typing everything yourself, you're editing a draft that sounds like you. So that's ambient in a nutshell, a scribe that scales. Now, I know we're all evidence-based clinicians, so anecdotes aren't enough. What does the research say about ambient AI? So let's look at the data. At Mass General Brigham and Emory, a study published in JAMA Network Open found a 21% absolute reduction in clinician burnout, a 30% improvement in documentation-related well-being. Those are massive effect sizes. We almost never see that big an impact from workflow interventions. The Class Arch Collaborative has also studied this. Their surveys show ambient documentation reduces after-hours charting, it lowers cognitive burden, and it improves overall EHR satisfaction. That's not just about saving a few clicks. It's about improving provider well-being. And that's important because right now, burnout is one of the top threats to physicians. We can't keep asking people to do more with less. Ambient AI is one of those few IT tools that's been proven to actually make things better. So when we talk about ambient, this isn't a gimmick. It's a validated intervention that can help keep us in practice. Let me bring it closer to home with our Parkview story. We started small. We piloted Microsoft Nuance DAX Copilot with a limited number of licenses. We wanted to see, would it actually work in real visits? Would clinicians accept it? Would it hold up with compliance and coding? The feedback was overwhelmingly positive. Physicians told us things like, this is the first IT tool that feels like a gift, not a burden. I had more eye contact with patients than I've had in years. And my notes sounded like me. Mine didn't. They sounded better, but good for you. We checked with coding and compliance. Were the notes accurate? Yes. Was billing at risk? No. If anything, documentation completeness improved. So we built an expansion plan to roll out to all ambulatory ED and inpatient providers. We launched all ED on one day, and then we did inpatient pilot, and then rounded out to all inpatient providers at Parkview in September of 2025. This was one of the largest ambient rollouts in the Midwest. Well, why does this matter? Well, because providers are the ones who are drowning in notes, refills, and messages. This isn't just about saving time. It's about restoring joy in practice. Now, let me get very practical because tools are only as good as workflows. So here's 4 tips for making ambient AI work for you. Start with style. Spend some time figuring out or writing down how you like your notes. For example, do you always start with the problems first, like APSO format instead of SOAP format? You may want to use concise phrasing for normal exams. Don't include any review systems unless you actually say it. Review systems hasn't been required in ambulatory since 2021 and in inpatient and ED since 2023. So don't put it in there. Feed that information into the system, adjust your user preferences, and it'll draft closer to your style. It's nice to configure all of this before you start using ambient and then make adjustments as you go. Look at some of the outputs and decide how you want to rephrase things. I always tell providers, you're not a New York Times best-selling author. Your notes don't have to be either. So see how it does an output, and maybe you can change how you write your notes. Next up, prime the system. You can dictate as well as ambiently listen with this technology. Think of it like you're giving the AI a prompt. So start each visit with a simple verbal cue. Patient name has a history of diagnosis 1, diagnosis 2, and diagnosis 3, being seen today for blood pressure follow-up, knee pain, and medication refills. That one sentence sets the AI up for success. It anchors the structure of the note. And typically, you'll have some of that information from your rooming staff or the reason for the appointment being scheduled already. Review and sign before the next patient. Ooh, if you can do this, it'll help your workflows. If possible, skim your draft before your patient leaves. A 30-second review saves you from a 10-minute re-edit at 9 p.m. Yes, it is possible with Ambient to finish a note after every single patient. Try it. And coach your patients. Don't just ask for verbal consent from the patient. A one-liner is enough. This tool is helping me capture our conversation so I can focus on you. I'll review and sign the note myself. Patients appreciate the transparency. The key takeaway, though, of all this is that Ambient works best when you work with it. Don't just let it run wild. Guide it and correct it, and it becomes your voice. So why does all this matter? Well, because burnout is the elephant in the room. Every survey shows the same thing. Physicians, especially primary care, are burned out. One of the top drivers is documentation. We spend, on average, 1 to 2 hours per day outside of clinic hours finishing notes. That's hours stolen from family, from sleep, and from recovery. Ambient AI tackles that directly. It doesn't just eliminate documentation, you still review and sign, but it shrinks the burden dramatically. Instead of reconstructing an encounter hours later, you just confirm what was already drafted. And burnout isn't just about time. It's about energy. It's about attention. When you don't have to split your brain between typing and talking, you can actually focus on the patient. You make eye contact. You listen fully. Patients notice that, and they feel more cared for. At Parkview, physicians using Ambient told us, for the first time in years, I left my clinic with all my notes done. That's not just about it's not just about efficiency, it's about reclaiming joy. And when doctors feel better, patients feel it too. Satisfaction improves on both sides in the exam room. So ambient AI isn't just a technology, it's a well-being intervention. It's one of the few IT investments that has published evidence showing that it reduces burnout. That's why ambient matters, because it's not flashy, because it's one of the first tools that actually gives us our time and humanity back. All right, let's shift gears into the safe use of AI. Now, before anyone gets too excited about AI saving the day, we need to talk about something a little less glamorous, but absolutely critical: governance. Here's the truth. Clinicians are not allergic to innovation. We're allergic to unsafe innovation. We've seen this all play out before. A predictive score that didn't apply to our population. An alert that fired at the wrong time and created more harm than good. A quality measure that added clicks but didn't improve any outcomes. If we don't have guardrails, AI will become the same story. More noise, less trust, and clinicians tuning it out. That's why governance matters. Governance is the process of asking what counts as AI in our system, who approves the new tools before they go live, how do we test them in our environment, how do we monitor them after rollout, how do we pull the plug if they cause harm. Without governance, AI feels like a black box imposed from above. With governance, it feels like a clinical tool we can all trust. AI without governance is like giving your teenager the car keys without asking where they're going or when they'll be back. It might work out fine, or we might get a call from the police. So if we want adoption, if we want trust, governance isn't optional. It's the foundation. So what does good governance actually look like? At Parkview and at many other systems, we've modeled our approach on the NIST AI risk management framework. It comes down to 4 verbs: govern, map, measure, manage. And I added a 5th called message. So for govern, set the policies, decide what counts as AI, create an intake process for new AI projects, make sure there's a committee that includes clinicians, IT, legal, compliance, and safety. If you see a new AI tool, put it through your governance at your system. Map it. So understand the context. What's the use case? Who will use it? Is it helping with inbox drafts? Is it predicting sepsis? The level of scrutiny changes depending on that risk. Measure, evaluate the performance. How accurate is it? What's the sensitivity, specificity, positive predictive value? How does it compare to current practice? Is it safe across different subgroups? Manage, monitor it over time. Models drift, populations change. If you don't watch performance, accuracy decays. So build in monitoring and feedback loops. And then here's my added fifth called message. Communicate with clinicians. Tell them what a tool does, why it exists, and how it was validated. If we roll out AI without communication, people won't trust it. Governance isn't red tape. Governance is how we make sure that AI helps instead of harms. It's how we build clinician trust. Which brings me to the next critical piece called transparency. If we want clinicians to trust AI, we have to be honest about what it is and how it works. Clinicians should always know when an AI tool is running, what data it's using, why it's making a recommendation, and how they can override it. The ONC HTI-1 final rule now requires certified EHRs to provide more transparency for decision support interactions. That is a good step, but internally we need to go further. So here's what it can look like in practice. Label AI outputs clearly in the EHR. If it was a draft generated by AI, mark it as generated by AI. Epic has this little icon called a bloom that shows up everywhere the AI is being used. Provide a why this fired button or something similar. Show the factors behind the prediction. Publish validation metrics internally. Show how the model performed in our population, not just somewhere else. Make it easy for clinicians to give feedback when something goes wrong. Think about medications. We never prescribe a drug without knowing what it is, what it does, what the side effects are. AI should be no different. If a computer is whispering in my ear during patient care, I at least want to know who trained it and whether it's passed board certification. Transparency isn't a luxury, it's the price of trust. And without trust, AI won't get adopted no matter how fancy the tech. All right, so let's zoom out for a minute and talk about the regulatory environment here in the US, because AI isn't happening in a vacuum. There are already rules in place governing AI, and more are coming. First, that ONC HTI-1 final rule I mentioned. This requires certified EHRs to be more transparent about decision support interventions, including AI. So if Epic or Cerner deploys an AI model that influences care, they have to disclose information about how it works and what data it uses. That's a big deal for transparency. All right, the FDA. The FDA regulates AI and machine learning enabled software as a medical device, or SAMD. If an AI tool is making diagnostic or treatment recommendations without a clinician in the loop, it falls under FDA oversight. They've already cleared dozens of AI tools, especially in radiology. HIPAA. This one hasn't changed. If an AI tool is handling protected health information or PHI, it has to comply with the same privacy and security rules as everything else. Audit trails, encryption, access controls, all of it applies. Tools like Epic's Cosmos use the HIPAA-defined limited data set of de-identified patient records. There's an example. And finally, for now, the FTC. The Federal Trade Commission has warned vendors about AI washing. In other words, don't slap the word AI as a label on your product unless you can back it up. If claims are misleading, the FTC can take action. The FTC basically told companies, you can't just add AI to your brand name like it's gluten-free and expect people to buy it. So the message is if regulations already exist, more are coming, and we as clinicians need to understand the guardrails so we can advocate for tools that are both safe and practical. But now let's look at the state level because states aren't waiting for Washington to figure this all out either. The biggest example is Colorado's AI Act. Passed in 2024, it goes into effect in 2026. It requires both developers and deployers of high-risk AI systems, healthcare definitely counts, to do impact assessments, monitor outcomes, and provide transparency. This means health systems in Colorado will have new responsibilities, not just their vendors. California has jumped in too with AB 3030 passed in 2025. This law requires disclaimers if patients received AI generated healthcare communications. It also adds rules around insurers using AI for coverage decisions. Other states are exploring similar bills. Some focus on transparency, some on bias, some on liability. In Indiana, I'm advocating on a Senate AI healthcare committee for incentivizing adoption and local validation of AI tools, especially for those in rural areas. Because let's face it, AI is expensive. And if just larger systems are able to benefit from AI tools, we're going to have AI equity issues, which then in turn lead to patient care and quality issues. The big picture, we're heading for a patchwork. If you practice across multiple states, you'll need to be aware of multiple rules. It's kind of like telehealth laws all over again. One state says yes, another says no. The clinician just wants to know if they can see their patient, and use tools without breaking the law. So the point here is governance at your health system is important, but you also need to know what your state legislature is cooking up. And now internationally, the most important development here has been the European Union's AI Act adopted in 2024. This is the first comprehensive law regulating AI across all industries, and healthcare is considered in that high-risk category. That means that AI tools must have robust risk management processes. Training data must be high quality and representative. There has to be transparency on how the AI works, and there must always be human oversight. Now, you might be thinking, that's Europe, not us. Remember, Epic, MEDITECH, and Oracle all have European clients. If their tools have to meet the EU standards, those same standards may shape the products we get here. And patients are paying attention too. If patients in Europe are told this AI was tested, validated, and labeled high risk, well, American patients are going to expect the same too. So even if US law lags behind, the global environment will still shape what lands in our workflows. In other words, Brussels may end up deciding how your EHR works. Who saw that coming? One of the biggest risks with AI is bias. AI models are only as good as the data they're trained on. If that data reflects inequities, the model will too. We've already lived through this in medicine. Think about the EGFR calculation that adjusted kidney function based on race. It systematically delayed referrals for African American patients. That wasn't intentional, but it was baked into the algorithm. With AI, we risk repeating those mistakes on a bigger scale if we're not careful. So what do we need to ask about every model? So was the training data diverse? Was the model tested across age, sex, race, and socioeconomic status? Is there a plan to monitor bias over time? If not, we risk widening disparities instead of closing them. And as physicians, we're often the ones who see those disparities first. We know when a tool doesn't fit our patients. So our role isn't just to use AI, it's to advocate that AI be built and monitored ethically. Because the last thing we need is a predictive model that works great for a marathon running tech employee in Silicon Valley, but it fails for our patients who work night shifts at a factory. Equity isn't optional, it's central. And if AI is going to scale, it has to work for everyone. All right. So I've got some key takeaways. Let's bring this all together. We've covered a lot of ground in these last hour or so. So let me boil it down to a few things for you to learn. So AI is not new. It's been part of our workflow for decades, from drug-to-drug alerts to predictive scores to dictation. The difference now is that the technology is finally powerful enough to matter in daily practice. Second, not AI is all the same. We walked through the spectrum. Rule-based systems are predictable but brittle. Machine learning finds patterns but has to be validated locally. Neural networks handle speech, but they're images, but are like black boxes and hard to figure out. Generative AI creates drafts but can hallucinate. Agentic AI is emerging, taking actions, not just drafting. So third, look at the workflows. In the past, AI was clunky, but today it's already helping with inbox drafts, chart summaries, and ambient notes. In the near future, it'll prepare charts, build prior auth packets, and personalize care plans using scale like Epic's Cosmos. Fourth, ambient AI is real and proven. It reduces burnout, improves EHR satisfaction, and gives clinicians back their time. At Parkview, we're expanding DAX enterprise-wide because our doctors told us this is the tool that finally helps. Fifth, governance and legislation matter. Without guardrails, AI risks becoming another source of noise and inequity. With guardrails, it becomes a partner that we can trust. And last, providers won't be replaced by AI, but providers who use AI will outpace those that don't. This is about augmentation, not replacement, about freeing us to do the human parts of medicine better. That's the story of AI in medicine. Thank you all for your attention and engagement today. We've covered a lot. What AI is, the spectrum of AI types, past, present, and future workflows, ambient AI and its impact on burnout, governance, regulation, equity. This is a conversation we all need to have as clinicians because AI isn't coming in the future. It's already here. And the more we understand it, the more we can help shape it into something that actually helps us and our patients. So when you hear the hype about AI, don't picture robots with stethoscopes walking into your exam room. Instead, picture fewer clicks. Picture finishing your notes on time before you leave clinic. Picture your inbox messages already drafted, your prior auth packets already prepped, and your documentation sounding like you instead of a template. That's the promise here. Not science fiction, but tools that make our jobs sustainable again.